Congress, and I think that what you did in this session is to address the importance of invasive technology as a new opportunity to increase the powerful of emergency medicine worldwide. I really am happy to address this topic. And this topic is coming as the need, and we use this representation to work together. Not only emergency physicians, but radiologists, interventional cardiologists, to produce more evidence and publications, as we did into the great network, worldwide academic research organization that is with Watson worldwide trying to increase the powerful of publication in our group. And I really appreciate that you put in the backs many journals, because this is the future of emergency medicine, to produce evidence. So let's go now and see, after my disclosure, what are really the need for technology support after clinical evaluation. Before starting my talk, let me tell you that no technology can support a bad emergency physician, because the best technology emergency physician has is his holistic opportunity to visit the patients and make clinical decisions. By the way, in the last 25 years, we saw an important increase in quality of laboratory testing, especially biomarkers in acute disease and point-of-care biomarkers, but also technology of imaging. So laboratory testing and imaging are going to be the big revolutions in our job to increase the quality of our medical effort and, most importantly, increase patients' outcome. When you talk about imaging, for sure you know that ultrasound are totally changing our ability. Every emergency physician now are able to perform ultrasound, and I'm very proud that we were the people that teach cardiology on how to use chest ultrasound to detect many diseases they were not able to do. But nevertheless, besides the ultrasound that are growing impact, there are other technologies such as point of care, looking at the computer-assisted imaging, but last but not least, the angiography. Angiography is really important, and I think it's something that can really improve our knowledge and also quality of health delivery system. But of course, the issue here that angiography need a cath lab, or let's say radiology interventional box that should be as much as possible close to the emergency room. So this is the first example. 250 years ago in my regional city, Naples, these researchers put some substance into the vessels of humans, and these skeletons are still there in Naples, one man and one woman, and you see he put these injections, but unfortunately patients died. But luckily now we have many different radio contrast possibilities that are able, thanks to invasive medical imaging technology, to use this iodinated contrast material to visualize the lumen of blood vessels. And this is very important because thanks to the angiography, now we can have a very clear opportunity to see the brain, the neck, the aorta, the chest, the gastrointestinal tract, and so on. But what is important, not to abuse the technology, but to make the right decision. First of all, now blood vessels should be evaluated also with non-invasive technologies such as ultrasound, echo Doppler, TC scan, and magnetic resonance imaging. Nevertheless, although these new non-invasive technologies are going to be every day much more precise, we still need angiography, catheter-based, in the cases you need immediately decision-making to transfer the patient to surgeon, or last but not least, to have access to intervention radiology procedures that can impact the length of stay of our patients in the emergency room, and also to reduce the length of stay in the hospital and the costs related. So this is the way you have to think about how angiography can really increase our emergency department job every day. So I have one question for all of you. How many of you today have an angiography service available 24 hours, 7 days in your emergency department? Please raise your hand. Not so bad, 15%. Okay, let's see if the other 85% could be convinced at the end of my talk to try to insist to have an angiography box in their emergency department. So, and I think this is coming to the fact there are so many acute diseases that are elencated here, such as acute myocardial infarction, multiple pulmonary embolism, trauma, that can benefit having an angiography area into the emergency department. First of all, let me address my special topic, acute coronary syndrome. We know that time is myocardium, so you really want to start as soon as possible in the emergency department to reopening the vessels in the case of MI. These recently published 2019 guidelines on how and when to perform angiography in acute coronary syndrome is very clear that in the case of elevated ST myocardial infarction that is within 12 hours, you should do evidence 1A, in all these cases, a PTCA. And then that is a delay opportunity, still evidence 1A, if you have no cath lab available, that you can do fibrinolysis. So in any way, you are going to perform in many patients as soon as possible angiography, coronary angiography, and then opening the vessels. This is a cartoon that I would like to take in mind, but I'm sure everyone in the audience is aware. In the case that you are able to make EKG in 10 minutes, and you are going to refer an hospital where the cath lab is not available, you have two choices. If you are the STEMI, in between 120 minutes, in that case, you can refer for 90 minutes, transfer the patients. Alternatively, if you have 2 hours that the STEMI is started, you can start fibrinolysis there, and then you can reperform in 10 minutes, transferring the patients. But if you have the cath lab, angiography, and the coronary PTCA available, you should do this in less than the 60 minutes. I think it's very important to save as much as possible lives in acute coronary syndrome in our patients. What about if I have a patient with not ST myocardial infarction elevation? In this case, there is the opportunity, if the patient is very high risk, also to go for invasive procedures if the patient is hemodynamic instability, if there is life-threatening arrhythmias, and also acute heart failure. So still in these patients, you can do PTCA within 2 hours. So something that you could do there, because you are going to save and increase the number of lives in the emergency department. So let's move now. Another important frequent reason for patients coming, pulmonary embolism. In this consensus statement for multidisciplinary physicians, it's very clear that in the case there is a big embolus that is very close, massive embolus, very close to the original pulmonary artery, you should do catheter thrombolysis and removal of the thrombus. So it is very important also to consider in patients presented with the syncope, massive TC scan, pulmonary embolism, to do angiography and remove the clot. Now, what about the need also to look at the aorta during patients coming in? I'm sure experience with patients coming with chest pain, you are looking for acute myocardial infarction, the patients can have aortic dissection. So aortic dissection is really a situation where the emergency physician can have the need to make aortoangiography. What the guidelines say that the most risk is the ascendant aneurysm and the dissection, where the patient should be immediately treated with the beta blockers. All these patients should have beta blockers and then transfer immediately to cardiosurgeon in order to make a decision. So aortic dissection is another really important situation when you need angiography to perform as soon as possible. Now, I'm sure also in your daily practice experience, you are managing with the patients come in with acutely cool, painful leg, and in this case, you really are going to clinical put a suspicion of acute limb ischemia. In this case, you can perform a Doppler that is mandatory, and in the case of Doppler, you can have three possibilities. Assuming that you have no artery in the, let's say, pink area, sound, no vein sound, don't waste time. Ask the surgeon to make amputation on the leg. On the other side, in the green area of this cartoon, if you have a presence of audible artery and veins, you are going to do angiography because you want opening the vessels that bring blood to the limb. So I think it's very important also in the acute limb ischemia after the clinical judgment and also non-invasive assessment to go for an angiography. Now, another important issue where the angiography is going to be increased, the role is a stroke, both ischemic and hemorrhagic stroke. In ischemic stroke, in the case of these 6 possibilities, pre-stroke MS score between 0 to 1, causative occlusion of the internal carotid artery of MCA segment 1, age greater than 18 years, NAIHSS score greater than 6, aspect greater than 6, treatment of removal. The occlusion of the artery should be done after angiography, but in the case of the symptoms are greater than 6 hours, and you cannot do thrombolysis. But what is important, this leads to the need, like the recommendation, guidelines 2018 are going to put out the importance of a multidisciplinary team that is my auspicious in this conference. Opening the ceremony, I think is a very good opportunity for me to tell that we have to work all together in order to improve our skills and patients' treatment. And also it is important that angiography should be there in the case of ischemic stroke. And also it is important that you want to monitoring. So our job is not only to start appropriate treatment, but to monitoring patients' outcome and publications on the results. What about hemorrhagic stroke? There is no doubt there are a lot of situations where you can use clipping or culling of the hemorrhagic site after brain angiography, and then you can save the patients, especially if he has hemorrhage due to cerebral aneurysm. So it is very evident that so far we addressed the important possibility to check in the case of acute coronary syndrome, acute aortic disease, and acute stroke, the possibility to use angiography. Now, what about trauma? There is no doubt that looking at a lot of bleeding that are going to be not able to stop because of what you're doing with the medical treatment, you should need an angiography. In this case, what is important as an example of the very severe trauma is liver trauma. In the liver trauma, you should consider 2 classifications. AAST, liver trauma classification,